Let's start with the language of infection. Acute infections resolve quickly, like strep throat or influenza. Chronic infections last longer than 2 weeks and may be incurable. We also classify infections by spread, localized to one area, disseminated when they move beyond the initial site, and systemic when the whole body is affected, such as sepsis. Finally, remember the difference between an epidemic, which is a spike in cases, and a pandemic, which is a global. Infections are often categorized by the causative agent: bacteria, viral, fungi, or parasites. This helps guide both the diagnostics and the treatment. Pathogens vary in virulence. Some, like HIV or TB, are highly virulent, highly contagious. Others are weaker but still communicable, sometimes even before symptoms appear, like influenza or HSV. Some remain dormant, such as varicella, and can reemerge later as shingles decades later. Risk depends on both population and individual factors. Infants, older adults, and those with limited resources are more vulnerable. Immunodeficiency, chronic disease, and environmental exposures also increase risk at the individual level. When you reduce vaccines, you also can reduce it at the herd level or at the population level. When assessing infection, we gather history, injuries, exposures, travel, medications, and perform a head-to-toe exam. Always remember, be the nurse first. Diagnostics include labs like CBC with the differentials, cultures, CRP, ESR, and imaging as needed. Prevention is always key. Primary prevention includes hand hygiene, precautions, and immunizations. Secondary prevention includes screening, such for STIs, and collaborative interventions ranging from PPEs and isolation protocols to include antimicrobial, nutrition, and fluids. Acute infections are things like strep throat, influenza, and otitis media. Strep is bacterial and requires antibiotics. Influenza is viral, so treatment is generally supportive, while otitis media is common in children and is often linked to smoke exposure. It may require antibiotics, although antibiotics are not always your first option of intervention. Strep throat is caused by group A streptococci. It can lead to complications like rheumatic fever if untreated. Symptoms include fever, headache, abdominal pain, and inflamed tonsils with exudate. That's the white stuff you see in the back of the picture here. Diagnosis is by rapid antigen test, which may or may not always be the most accurate, and throat culture, which is generally the gold standard. Treatment is antibiotics. Nursing care focuses on comfort: compresses, gargles, analgesics, and fluids. Education is critical. Complete the antibiotic course, stay home for 24 hours after starting therapy, and replace the toothbrush after 24 hours. Nursing care focuses on comfort: compresses, gargles, analgesic, and fluids. Education is critical. Complete the antibiotic course and stay home until 24 hours after starting therapy, and always replace the toothbrush after 24 hours to prevent reinfection. Influenza is caused by the orthomyxovirus, spread by droplets in contaminated surfaces. It is most infectious before symptoms appear. Complications include pneumonia and myocarditis. Symptoms range from fever and cough through fatigue and GI upset. Management is largely supportive, with antivirals in some cases. Prevention through vaccines and hygiene is always essential. Otitis media is a middle ear infection, often viral or bacterial. Risk factors include bottle propping, or leaving the baby in the crib with their bottle, smoke exposure, and upper respiratory infection. Symptoms include ear pain, irritability, and sometimes discharge. Diagnostics is by examining the tympanic membrane visually, and treatment may involve antibiotics, pain relief, and in chronic cases, tympanostomy tubes. Antibiotics are not always the first option. And this slide demonstrates one of the hallmark indicators of otitis media, is that the child is pointing or pulling on their ear. This can be seen in children who are not even verbally competent yet, or those who are otherwise mentally challenged. Be looking for the ear pull. In the treatment of otitis media, be aware that symptom relief can include ibuprofen and acetaminophen, as long as the child is above 6 months. We do not give ibuprofen to any child under 6 months. And always remember, we don't give aspirin to children as a risk of Reye's syndrome. Refer to your textbook for the specific age, but I believe it's under 7 years old. Always remember that as a nurse, one of our first roles is education, so we're always going to be talking about prevention, completing the antibiotic therapy, and working on ways to reduce the risk. And if we are working with a child with a tube, be aware that they cannot get water into the ear because the tubes will allow water to enter into the medial canal, further increasing the risk of infection. I used to work in this surgical procedure back in the old days. This is a simple procedure. Basically, the surgeon comes in, opens up basically a needle, punches the needle in, pushes a tube in, and pulls the needle back out. Very much like sticking in an IV catheter. We stick the needle in, the catheter remains behind. The trick with this is that many times this little tube falls out under its own, and there is a lot of debate with the effectiveness of this tube, but it is one way to relieve pressure on a kid who is chronically infected. Gas exchange disorders include asthma, chronic cystic fibrosis. Risk factors for impaired gas exchange include age, smoking or secondhand smoke, chronic disease, immobility, and aspiration, to include aspiration pneumonia. The process of gas exchange is a fairly linear process. Atmospheric gas is primarily 21% oxygen, enters into the into the throat, either through the nasal cannula or through the oral. Drops down to the trachea, the bronchi, and into the smallest sacs of the lung, also known as the alveoli, at which point pulmonary capillaries with hemoglobin pick up the oxygen in exchange for carbon dioxide, and then through perfusion transports this using hemoglobin to the cells, at which point the cells will metabolize, and then transferring the carbon dioxide for the oxygen, the hemoglobin will transfer the carbon dioxide from the cells to the pulmonary capillaries, back up to the alveoli where it is exchanged through the bronchi, trachea, and not back out either through the nose or through the oral, and then again released to the atmosphere. Risk factors of impaired gas exchange. Age. Keep in mind that the youngest infants have a very large head and very small body mass, making it very difficult for them to turn their head if they are placed face down. Always remember the SIDS protocol: on their back, alone, and with nothing else. Smoking secondhand is generally causing a big problem with the impaired gas exchange, and chronic medical conditions including COPD, cystic fibrosis, and heart failure. Immunosuppression is always a factor, as well as aspiration, very common in the very young and the very old. And with that comes tracheal intubation patients who create their own risk. There is also a reduced state of cognition, bringing problems of aspiration. This reduced state can be caused by brain injury, alcoholism, by both the mother or the teen, and drug overdose with anesthesia. Prolonged immobility causing decreased lung expansion, which we discussed previously, and infants and children, because of their smaller volume, have less alveolar surface for gas exchange and reduced airways that can become compacted. When you're doing your respiratory assessment, always remember to include the history, lifestyle, and exposures. Your exam is going to cover all the vitals, inspection, and of the breathing effort, and skin color with auscultation of all lung sounds both front and back bilaterally. Keep in mind that the very young, especially infants and toddlers, will do abdominal breathing. This is normal. Diagnostic testing for gas exchange includes arterial blood gases, CBC, sputum, imaging, pulmonary function studies, endoscopy, all which help identify the cause and severity of impairment. Sputum exams are very difficult to get accurately and effectively. Many of the times you just end up with a mucus from the nasal cavity, which is not always going to be helpful. Primary prevention for impaired gas exchange is always infection control, smoking cessation, or prevention. If you can get the kids to not smoke in the first place, it's always helpful. This includes all forms of smoking, whether it's vapes, tobacco, or other materials and substances. Immunizations are always key, and preventing post-op complications is one of the primary functions of nursing. For collaborative interventions for impaired gas exchange, we're always looking at pharmacotherapy. Various types of drugs that we will use will be antihistamines, both prescriptive and over-the-counter, decongestants, and bronchodilators. Albuterol being one of the primary ones to increase gas exchange by opening up the airways. Mucolytics, making mucus more viscous so it's easier to cough up, so you don't have a mucus plug blocking up airways. Cough suppressants if your cough is consistent and non-productive, keyword and non-productive, along with antimicrobials. Nutrition therapy, high protein, high calorie, secondary to increased work of breathing. And always remember, positioning is key. We are built to be vertical, and the more vertical we are, the better the lung excursion, allowing us to breathe more effectively. Chest physiotherapy and postural drainage, especially when we're talking cystic fibrosis patients, and oxygen therapy as a supplemental for all. ARDS, or acute respiratory distress syndrome, is life-threatening, often triggered by sepsis, pneumonia, or trauma. Fluid leaks into the alveoli, impairing gas oxygen exchange. General symptoms include severe shortness of breath, hypoxia, and unresponsive oxygen. Management does require ICU care, ventilation, and treating the underlying cause. So always remember, we have to identify the underlying cause before we can have effective treatment. I want to bring attention in this slide to the complications, multi-organ failure, specifically the brain, heart, and kidneys from hypoxia. If you do not have oxygen perfusion, oxygen getting to the bloodstream and through the bloodstream, you are going to have a great deal of difficulty keeping organ function at any level. Difficulty can include pulmonary fibrosis in some survivors, and there is a high mortality. Survival is 55 to 70% if you get proper treatment. And remember, ARDS requires ICU care with mechanical ventilation in order to be most successful. I know this is the first time you guys have ever discussed asthma in your nursing program, but keep in mind that asthma is a chronic inflammatory disorder of the airways. Exacerbations make it hard to move air in and out of the lungs. The triggers include allergens, exercise, and smoke. Symptoms are wheezing, cough, and chest tightness. Diagnosis includes using a pulmonary function test, among others. Treatment includes bronchodilators, corticosteroids, and long-term control medications. Peak flow meters help patients monitor airway narrowing, and pulmonary toileting is also key. Keep in mind that you may see something like this again in the not-too-distant future. Again, the diagnostics for asthma includes a pulmonary function test, and medications are bronchodilators, specifically albuterol for rescue, and for acute exacerbations before and after exercise. Montelukast is mucolytics, help to break up mucus buildup and help control the productivity of the cough. It is generally a long-term control medication. Anticholinergics, including atropine, can be used to help maintain the airway. Corticosteroids for inflammation and to decrease airway inflammation. Keep in mind that when you have corticosteroids long-term, be aware to be looking for long-term side effects. And we also use inhaled corticosteroids, most specifically flute. So be aware that these are fair game for the exam. As part of our education, as nurses, we need to teach patients how to use the peak flow meter. This allows the patient to be more aware of their airway situation, and if they see their airways are starting to narrow, they can take medications to prevent the asthma attack from ever happening. The trick is to use it at the same time every day and make sure that the marker is set to 0 every time they use it so you don't get a false read, and to use this appropriately by standing up, blowing out as hard as quickly as possible, and recording your highest number after 3 attempts. Also, the parents need to be aware that the pollen counts or other atmospheric particles are high to keep the child indoors. Keep in mind also that when you have asthma, the complications of status asthmaticus is a critical emergency. This is where the airway obstruction is unresponsive to normal treatment and respiratory failure is imminent. We need intubation. So we have to teach the parents the signs and symptoms so that they can be prepared to bring the child in. Now with cystic fibrosis. Cystic fibrosis is an inherited disorder of the exocrine glands creating thick mucus. There's some pancreatic insufficiency and a multisystem complication also related to this. Respiratory symptoms include wheezing, cough, and recurrent infections. GI symptoms including malabsorption and bulky stools. Management involves airway clearance, antibiotics, pancreatic enzymes to offset the failing of the pancreas, and nutritional support. I want to tell you that there may be a genetic question on your exam related to cystic fibrosis. If mom and dad are both carriers, there is a 50% chance that the child will have cystic fibrosis. If one parent is a carrier, there is a reduced opportunity, roughly 25%, that the parent will pass on the cystic fibrosis gene to the child. The key thing to remember about cystic fibrosis is that there's an increased viscosity, increased thickness of the mucus. This creates a increased resistance to ciliary action. This is the little hairs inside your lungs and bronchial tubes that allow the mucus to leave. Thick mucus keeps those hairs from moving, which means that mucus stays in the lungs, causing blockage and mucus bronchial plugging, causing respiratory failure. Now, I want to tell you guys, I know we talk about cystic fibrosis as being a respiratory disease. It is far more than respiratory. It is systemic. We know about the bronchi blocking off the bronchial movement of mucus, causing pneumonia or emphysema. But it can also create thick mucus blocking the small intestine, causing intestinal obstruction of a newborn, and pancreatic ducts, causing malabsorption syndrome, and even in the liver where it can block off the bile ducts, causing portal hypertension. And yet another source of good test questions here. Keep in mind that there is a good many details related to cystic fibrosis, how it does affect every major organ system. So please pay attention to this slide. The key thing to remember when you're looking at this slide is that it speaks like I do, so I'm going to translate. When it talks about mechanical obstruction, it just means it plugs up the pipe. When it talks about accumulates, dilates, precipitates, coagulates, that means it forms a puddle, it stretches out everything that it's sitting in, and it will congeal and thicken up like wet concrete, which is the second frame, concretions in the glands and ducts. So it will not only cover them, it will fill them, and then it will solidify, and once it's solidified, it's not coming back out. And keep in mind the respiratory tract and pancreas are predominant. They are not the only thing affected. This is what we refer to as the sweat test. When the pancreas is involved, it decreases its ability to secrete bicarbonate chloride. As a result, it is increased in the saliva and sweat glands. So in the saliva and sweat glands, it's going to have an increase in the normal volumes, from the normal volumes of sodium and chloride. This is used universally in neonates and toddlers, and will help identify the presence of cystic fibrosis situation, at which point we will then look for a DNA identification of mutant genes. This is another reinforcement of cystic fibrosis. It presents with a wheezing, non-productive cough with obstructive emphysema, so the airways are blocked and stretched. You're going to have patchy atelectasis, which means the villi are going to be blocked, and if you look at the slide on the right as opposed to the slide on the left, you've got a lot of airway crud in the lungs. You're also going to be looking at cyanosis of the skin. You actually turn blue, and the fingers and toes start to clubbing because of perfusion issues. And you also have chronic bronchitis and pneumonia. And that is generally what will take you out. As far as the GI is concerned, you're going to have partial obstruction of the intestinal tract causing malabsorption. You can't absorb minerals and nutrients from your intestines if your intestines are covered in crud. And because of the thickness and pure weight of the mucus, intestinal motility is diminished, causing constipation, among other things. And when they do have a BM at some point, it is very evident in the smell because the food is undigested. There's also going to be a lot of foam involved because of the protein reacting with the gases. Prolapse of the rectum, which means that the rectum flips inside out and sticks out of the back end of the kid, looking a lot like a tail. This is due to the strain related to the mucus plug being forced out of the body. You're going to have straturia, and with this comes malnutrition on top of the coughing. As a result of all these complications, you're going to have delayed puberty in girls. Boys are going to be sterile because of increased thermals related to the gonads, as well as poor circulation in the reproductive tract. When parents kiss their kids, the kids taste salty, which is one of the key indicators that we have a problem. And as a result of all this sodium chloride moving through the wrong channels, you're going to have chronic dehydration with hyponatremia, hyperkalemia, and alkalosis. You can also have hypoalbuminemia, which means that the proteins in the bloods are going to be greatly reduced, mainly because of the inability of the body to metabolize proteins effectively. I don't know if I mentioned one of the cystic fibrosis that you have thick, viscous mucus blocking off all the airways. I don't know if I've mentioned that before, but this will cause the airways to block off, causing difficulty in breathing, and one of the things we're going to be looking for is infections, which will be present with all patients at some point in time. Onset and extent is variable with patients depending on the intensity of secretion of the mucus. We're going to be doing careful history, physical exam, and looking for pulmonary infections, notably fever, tachypnea, and chest pain. They may or may not be present at all times. I will say that cystic fibrosis is progressive. Back when I started, if you saw your late 20s, you were unique. Nowadays, due to progressive treatments, it is possible to get much older than that now. However, at some point in time, it will catch up to you. So, with cystic fibrosis, respiratory management, if you see on the right is a percussion vest. It's a pneumatic device which actually packs pounds on the back of the chest of the child and adult now, causing the mucus to break free from the walls of the respiratory tract. And then when you flip the child into what they call a pulmonary toileting position or a head down position, it allows the mucus to be expressed through the mouth. This was actually something discovered by a mother who refused to let her child die. And because of this, we were able to extend the life of cystic fibrosis patients. It will require cystic fibrosis is aggressive, and it does require a lot of effort, medications, exercise, and humidity. So cystic fibrosis is both exocrine and endocrine. You may see this on a question. As far as exocrine, it's related to digestion by producing digestive enzymes. And when you have pancreatic fibrosis, these glands are blocked and the enzymes are not released, which makes digestion very difficult. As far as endocrine function, there are hormones secreted like insulin and glucagon that regulate blood sugars and causing cystic fibrosis related diabetes, CFRD. Also a very common exam question somewhere along the line. Another current diagnosis that you see a lot with cystic fibrosis is failure to thrive, FIT. This is related to a lot of the mucus blocking off a lot of digestive glands, enzymes which allow and support digestion. And because of this, the fat-soluble vitamins intake or metabolism is decreased. So we support this by creating more vitamins in the system by giving them vitamin supplements, A, D, E, and K primarily. We also can increase some of the enzymes that are given. These have to be given within 30 minutes of eating, and they are in terracotta, so don't crush. The powder form can be used with infants and young children. However, you got to make sure that this is not inhaled, not only by the child, but by you as a caregiver, because these are some very fine dusts. And you can even mix it into certain things like cereal and certain fruits to help along. The problem is that this causes a lot of gas. Gas causes pain. There may be some loose stools and some bloating as related to the gas and some strategia. You've heard me talk about perfusion before. Perfusion relates to the blood flow. Central perfusion is related to cardiac output, where tissue perfusion is related to the arterial and capillary flow. When we're talking about perfusion impairment, we're talking about blockages, occlusion, constriction, narrowing the vessels, or dilation of the blood vessels, reducing the pressure of the blood so the blood doesn't actually go anywhere. Now, sickle cell is also a hereditary hemoglobulopathy. It's a malformation of the red blood cell. I want to bring it up into the picture that's on this slide. Those are not red blood cells, please. Do not look at that thing thinking, oh my God. No, those are not red blood cells in this picture. I don't know who put it there, but it is not red blood cells. A sickle cell is basically if you take a balloon and take out about half of the air. It just looks misshaped. It doesn't necessarily have to be any particular shape. It is very much a misshaped red blood cell. Because they're misshapen, they tend to obstruct the capillaries because they lock together and basically form a nice dam. And because of this blockage, they cause ischemia, pain, and organ damage. Diagnostics through newborn screening, hemoglobin electrophoresis, where we look at the quality and quantity of the cells available. We manage sickle cell through hydration, oxygen, pain control, and infection prevention. Nursing care is emphasizing the growth monitoring, nutrition, and psychosocial support of the child. The genetics of this disease is always fun to look at. However, I'm not going to drag you down into the weeds with me. It'll be suffice to say that the normal hemoglobin A protein is replaced with the hemoglobin S protein. S for sickle cell, A for the alpha type. So when you have hemoglobin S, the cells misform, forming into the sickle cell, and actually more of an S shape. These cells are rigid, not soft and flexible like a red blood cell, like a erythrocyte. They're hard. And because they're hard, they don't bend, they don't flow, they do clump together. And as I said, when you get these ischemics, they are painful. And everything downstream from this blockage is no longer perfused. They don't receive the oxygen and nutrient support. And that will cause the potential for large organ or large tissue infarct or failures or even death. And if this happens in the right organs, it can actually lead to the patient dying. So how do we find out about it? So we're going to do, normally in this country at least, so far, universal screening of newborns is standard. At birth, infants have about 8% of hemoglobin type F, fetal, where the hemoglobin is about half from the child and half from the mother. So the child would be fetal, hemoglobin F, and the adult, hemoglobin A, from the mother. Generally at birth, hemoglobin S sickle cell is low. However, when we do electrophoresis, where we actually run the cells through a gel under electrical charge, the sickle cell S does not move, and it then becomes easily identifiable visually in the gel itself. If you ever get the chance to watch this test being done, it's quite interesting. Gives you a whole new respect for Jell-O. This slide is always a good source for test questions, many different kinds. The central column tells you all of the different things that can happen as a result of sickle cell. The part A and B on the left tells you the side effects that to be looking for, especially the hemolysis, breakdown of red blood cells, and anemia. And the column on the right talks about how the blockages can actually form. So how do we manage sickle cell? First off, the biggest thing is get fluids in there, because we need to open up the plasma levels so that the sickle cells have a chance to move around. They don't block as much. Once you get that going, we're looking at vaso-occlusive crisis, which is managing the symptoms resulting of the blockages. Pain control is always a thing. I have had patients, we would start on lower tiers and go directly into morphine in very quick order. Oxygen is always a thing. Sickle cells do not carry as much oxygen as a normal erythrocyte. So any oxygen support we can give would be helpful, especially if there's any kind of blockages in any of the major organs. Hypoxia results in metabolic acidosis, and the metabolic acidosis increases sickling. Nice little cycle going. So we do need to introduce electrolytes to help offset the acidosis. People who have sickle cell must have, not should have. These are must have pneumococcal and influenza vaccines, meningococcal vaccines. Oral penicillin prophylaxis are recommended to reduce the chance of pneumococcal streptococcus. If they do have infections, we need to be very aggressive with it because the potential of perfusion failure is very high. Splenectomy. We remove the spleen. Why do we remove the spleen? Well, it's because the spleen is a reservoir of blood cells, and the spleen doesn't care if it's an erythrocyte or sickle cell. So whenever there's a trauma, the spleen releases these reserve cells. Well, if it releases a whole bunch of sickle cell into the bloodstream, we now create our own sickle cell crisis simply because of an unrelated trauma. So if we remove the reservoir, we remove that potential problem from happening. I'm going to bring to mind that it had nothing to do with this picture. What do we do with management of sickle cell anemia? Well, we monitor for growth. Why are we looking for growth? Well, it's because if you don't have good oxygenation, you don't have good cell metabolism, a lot of nutrients are not getting through the cells, so you're not going to have good growth. As a result of this, we're going to keep an eye out for failure to thrive. We're looking with kids positioning and promote venous return, because if the cells have a chance to pool, coagulate, and lock up, we're going to have a major blockage. Blockages cause problems, including pain. Diet, high calorie, because again, nutrients are going to be blocked because of poor perfusion. Protein, because of work of breathing, because remember, we don't have good oxygen perfusion. And folic acid. We're going to be monitoring for anemia, decreased perfusion, and shock related to fluid imbalances, among other things. Sickle cell crises are triggered generally by infection, dehydration, or stress. Complications include vaso-occlusive pain, splenic sequestering, acute chest syndrome, and strokes. Again, the blockages. Management involves rest, IV fluids, IV morphine, oxygen, hydration, and antibiotics to maintain and manage whatever infection has caused the problem in the first place. Education for families is vital. Early intervention for any fever, hydration, and recognizing any warning signs of the crisis. Another potential for this is cold temperatures. Why cold temperatures? Because they cause the veins to constrict. If you have a chance of veins to constrict, you have a chance of the cells to coagulate and causing blockages. Surgeries by themselves will trigger, and illness or stress will also trigger because of vasoconstriction. Sickle cell crisis complications. The VOC, vaso-occlusive thrombolytic, is the most common type of crisis. It is very painful. I've had patients come in, and as soon as they walked in, we dropped an IV for fluids, dropped some morphine in their veins just to catch up. Problem with it is a stasis of blood with clumping the cells in the microcirculation, which means that the capillaries of the tissues are blocked. So we have to drop fluids to help dilute the sickle cells, to help allow for movement of cells, to help allow for better perfusion. If we don't, this will lead to ischemia and then an infarct. That means lack of oxygen and cell death. Depending on whatever is downstream, it could be muscle, not so much a big deal, or it could be in the lung, pulmonary infarct, not always fatal, or in the brain. Can you say stroke? So this is a very big crisis. One of the signs, fever, pain, and tissue engorgement. That means swelling of the tissue downstream of the blockage. Splenic sequestering is also life-threatening. Death can occur within hours because blood pools in the spleen and gets locked into the spleen and can't come back out. So all your blood cells are now locked inside of the spleen and not in the blood vessels where they need to be. Profound anemia. We pull up a blood test and we find all we got is plasma. Not good for perfusion. Hypovolemia and then shock and then die. Other complications. Acute chest syndrome. This is a lot like pneumonia, acts like pneumonia. You have presence of a new pulmonary infiltrate. That means you got fluid in the lungs. Symptoms, again, has chest pain, fever, cough, tachypnea, wheezing, hypoxia. The other thing, as I mentioned before, CVA, cerebral vascular accident, can also be with a TIA, transitory ischemic event. Mini stroke and full strokes. This is the sickle cells block the blood vessels in the brain. Brain doesn't get oxygen for 3 minutes. We are having a stroke. Everything downstream of that blockage dies. Variable degrees of neurologic impairment, just like any other stroke. Recovery is also dependent on the magnitude and timing. Extremely difficult to treat. Aplastic crisis is generally caused because of folic acid being reduced in the bloodstream, or it can be caused by viral infection, but basically the red blood cells are destroyed. Again, another profound anemia in the cell counts, and pallor. Patient is notably pale. Again, because you don't have red blood cells providing the color in the blood. You don't have oxygenation, you fail out, and you can actually die from this in fairly short order. Another fun thing is hyperhemolytic crisis. Red blood cells, again, are being destroyed. You're going to see this in anemia. You're going to see this in jaundice. Why jaundice? Because red blood cells are made of hemoglobin, have a high load of hemoglobin on board, and when hemoglobin breaks down, one of the key components of hemoglobin is bilirubin. Bilirubin equals jaundice. If your liver is compromised because of a number of issues, the bilirubin continues to increase, you get jaundice, and jaundice will cause additional complications. Reticulocytosis, or immature red blood cells, are then being released because of the crisis, but they are generally so immature that they are less than compensatory. They are not helpful. So what do we do with this? Well, first off, we treat the emergency. We can provide rest to minimize the caloric use of the person. We're going to give morphine, pain, administer oxygen just to support what cells are functioning to get any kind of perfusion to the rest of the body as best we can. We're going to apply heat to the areas of pain, dilate the vessels, move the blood along. Hydration through oral or IV or both. Again, we need to dilute the cells out so that we can get things moving again. Electrolytes, because we have diminished a great many of them because of the crisis. Blood replacement for anemia. Remember, we're talking about the hemolytic nature of some of these crises. If you don't have red blood cells in there, we got to put some in there fairly quickly. Antibiotics for infection and sometimes even prophylactic. So care management. First off, we're going to be, what do we always say about nurses? We are the grand educators. We are the teachers. We're going to be teaching the family of the child to be looking for early intervention for fevers, antibiotic all the time, all is ordered. Looking for signs and symptoms of splenic sequestration, and avoid ice. Cold weather. Cleveland, wintertime, not good. We're going to always manage the importance of hydration to prevent the sickling and allow better perfusion. When we're in crisis, pain management is always the same. And then we're always going to have to be educating the family. Depression, anxiety, and fear with the patient is very common. Pain relief during the crisis. We're going to start with acetaminophen and ibuprofen. How long do we stay there with those? Depends on what's going on. If we're in true crisis, we're generally going to be working directly into the opioids. Toradol, IV is a good go-to. Sometimes we have to even higher levels than that. Now, meperidine, Demerol, is not recommended. Test question potential, test question potential, test question potential. We do not give meperidine for sickle cell because it's a CNS stimulant, accumulates with repetitive dosing, so the more we give it, the more it sticks around and can actually produce anxiety, tremors, seizures, and if you're a sickle cell, it can actually cause seizures. And normeperidine is a metabolite of meperidine. Ooh, there's a good question. I got to write that one down. Norperidine is a metabolite of meperidine. So what's the prognosis? Well, technically, we're going to say this with left side, right side kind of type of thing. First, we're going to say there is no cure. Then we're going to say there's a cure, but it involves a bone marrow transplant. Supportive care will focus on preventing sickling episodes and infections. Life expectancy is improved, but complications like stroke remain significant, and cardiac ischemia is always a real thing regardless of age. So, yeah, we can't cure it unless we do a bone marrow transplant, and trust me, a bone marrow transplant is a endeavor that requires a lot of effort on everybody's part. But theoretically, the potential is there. All right. That's, I think, all that I have for you guys with this recording. And now next week, you are back to dealing with me as a in person. So have fun. Good day.